Mic on? Okay. All right, thanks everybody for coming. We're here today to tell you about a significant event that has occurred today. New York today is submitting a Medicaid Waiver Amendment request to the federal government to allow the state to reinvest $10 billion of the $17.1 billion in federal savings generated through the historic effort of Governor Cuomo's Medicaid Redesign Team. This is a groundbreaking waiver amendment. It's designed to achieve the CMS triple aim of better health, better care, and lower costs. If approved, the state will reinvest federal funds saved as a result of the MRT's effort in a range of initiatives to enhance the quality and cost effectiveness of the state's healthcare delivery system. Moreover, the waiver funds will support implementation of national healthcare reform and will reaffirm New York's leadership position in that historic effort. While this targeted reinvestment will drive better healthcare outcomes and lower healthcare costs, the proposed waiver is budget neutral to the federal government. These federal reinvestment funds are essential given the continued financial challenges faced by all states, including New York. As you know, when Governor Cuomo took office, the state share of Medicaid spending was on a path to grow by 13%. To combat this, Governor Cuomo created the MRT in January 2011 and charged it with developing a multi-year action plan to achieve better care, better quality, and lower costs. The MRT worked in two phases. Phase one, completed in February 2011, the team recommended 78 initiatives that were enacted by the legislature. Many of these reforms have been completed, and following full implementation of phase one initiatives, total savings between state and federal government over the next 5 years will be more than $34 billion. In phase two, the MRT divided into 10 work groups to develop strategies to address a number of complex issues. These recommendations were compiled into the MRT action plan as phase two was completed in December of 2011. The multi-year action plan promises to improve health outcomes and quality care for more than 5 million New Yorkers who are Medicaid recipients and effectively bends the Medicaid cost curve. Significant federal savings have already been realized through New York's innovative MRT process, and further savings will occur as a result of the action plan. The MRT waiver is technically an amendment to the state's existing 1115 Partnership Plan waiver. The Partnership Plan waiver has been a primary vehicle used by the state to expand access to managed care, and therefore it aligns well with the MRT's Care Management for All plan. The Partnership Plan waiver also has substantial remaining budget neutrality. The capacity is $41 billion, which will be further augmented by the MRT action plan savings. The state's budget neutrality position will be linked to the state's Medicaid global spending cap. We estimate the MRT phase one initiatives will save the federal government $17.1 billion over the next 5 years. Phase two recommendations will further increase those savings. Today's submission is an historic milestone in both the state and federal dialogue, as well as the stakeholder dialogues that have been taking place throughout New York State. New York State is united in support of these much-needed reforms. We have with us today several representatives from all segments of the healthcare industry in New York who would be happy to add their particular points of view to my comments and those of Commissioner Shah. Governor Cuomo's innovative MRT has ensured broad support for this action plan by aligning it with national healthcare reform initiatives. Working in partnership with the federal government and stakeholders throughout the Empire State, we look forward to successfully implementing this innovative waiver approach to enhance the quality of healthcare and reverse the trend of escalating costs. Commissioner Shah?
Thanks, Jim. You know, as Mr. Intron mentioned, it's thanks to Governor Cuomo's Medicaid Redesign Team and the involvement of all stakeholders that New York is well positioned to transform not only the state's Medicaid program, but the entire healthcare system. In less than 2 years, the team developed a comprehensive multi-year action plan that promises to deliver what has been historically very hard to fathom in New York: better care, better outcomes at lower cost. The key elements of the Medicaid Redesign Team's action plan included the establishment of the first ever global cap on spending. Instead of growing 13% every year, we are now growing the Medicaid program at 4% every year. The elimination of the inefficient fee-for-service system was a next major part of the program. Instead of paying more for volume, we will now be paying for value. And finally, investments in new models of care delivery, such as the patient-centered medical home and health homes, promises to position New York for the future of healthcare delivery. The waiver amendment that we're talking about today is the capstone on the MRT effort. When approved, this unique and forward-thinking amendment will allow $10 billion of federal savings to be reinvested in all areas of healthcare in New York State. As a result, New York State will be a national model for how to achieve healthcare reform. And remember, these reinvestments not only benefit Medicaid members, but in fact all New Yorkers, including 1 million more New Yorkers who will now have insurance for the very first time, thanks to Governor Cuomo's health benefit exchange. I'd like to highlight some of the areas of investment in the proposed waiver. First, the waiver will bring significant expansion to the high-quality primary care. It will provide for the expansion of existing facilities and building of new facilities and new primary care clinics. This will substantially reduce the number of unneeded, expensive emergency room visits that currently occur today throughout the system. And moreover, it will ensure that all 5 million Medicaid members will have access to nationally accredited, patient-centered medical homes for their primary care. Second, the investment of more than $3 billion will help essential but financially challenged nursing homes and clinics, hospitals all across the state through a reformed healthcare environment. These reinvestments also call for the creation of about 3,000 additional supportive housing units. And supportive housing is proven to enhance health outcomes while reducing Medicaid costs by as much as $31,000 per person per year. Waiver funds will also strengthen the integration of care providers with the health homes model. Health homes bring together an array of providers from across the system in a team-based approach around patients with one or more chronic conditions. And it creates an efficient system that really looks to the patient for outcomes. The bottom line is this: investing in these and other innovative, patient-centered care models will improve care and lower costs. And with this important waiver amendment, New York will reaffirm its long-held position as a national leader in quality healthcare delivery and reform. The waiver amendment presents a unique and unparalleled opportunity to transform the way we care for New Yorkers. I'd like to urge every one of you, all New Yorkers, to actively support the governor in securing approval for this waiver. Quite simply, we cannot afford to live without it. Thank you. Jim, if you could introduce some of the stakeholders present, if we could get the list.
All right, this waiver is an extraordinarily complicated document, 127 pages, have I got that right? 127 pages, you'll find it on the Health Department website. There are 13 in the document. There are 13 major initiatives covering all aspects of the healthcare delivery system in New York. We've asked some of the stakeholders, important stakeholders that have helped us in crafting this waiver application to join with us today in case you have specific questions relating to particular parts of the healthcare delivery system. With us today are Paloma Hernandez with a urban health plan in New York City, Ted Houghton represents supportive housing providers, Debbie King, a leader in the training of the workforce associated with 1199, Dan Lowenstein, Director of Public Affairs for the Primary Care Development Corporation, Ken Rasky from Greater New York Hospital Association, Harvey Rosenthal from the New York Association of Psychiatric Rehabilitation Services, Dan Sisto, President of the Hospital Association of New York, and Beverly Grossman from the Community Healthcare Association of New York State. So they'll be here later if you have specific questions. Right now, Dr. Shah and I would be happy to answer any significant questions you might have.
So the $10 billion waiver request is federal dollars to New York State. If it were not approved, we would not be able to spend the $10 billion outlined in the program across all these areas. But remember, it will be approved because all of New York State will be behind it, and it makes sense. It's going to continue to accelerate the savings we've already made for the feds, and it's going to help the feds with their Affordable Care Act and finish what they've started with healthcare reform.
$10 billion of the $17 billion. You know, the waivers, Medicaid waivers are common. There are, I think, 37 states operate with Medicaid waivers. In recent years, we've seen other states undertake major restructuring through the waiver authorization. California recently did a $10 billion waiver. Texas, somewhat larger. Massachusetts, I think, also somewhat larger. We felt that that was the right size given the scale of our program and what the CMS has done in other states.
Sure, the question related to health homes, how they work and how they might save money. Health homes are a designation given to care coordination programs built around those complex, high-cost patients with 2 or more chronic conditions. So if you have hypertension, diabetes, 1 or 2 more conditions, things like that, you tend to be a high user of the system. What the system doesn't have right now is a good capacity for bridging all the links, connecting the nursing home to the hospital, to primary care, and everywhere else, so that the patient is viewed as one patient rather than through all these silos. Health homes, through Medicaid, are an attempt to link all these different systems of care so that we can get the patient's perspective and give the patient what they need, where they need it. For the first 2 years, 90 cents of every dollar toward health homes is coming from the federal government. So it's incumbent on us to bridge those silos, to create the links across the systems of care, and to really take a patient-centered perspective for those high-need patients. Once those links are built for those high-need patients, they'll still exist for everyone else, whether or not you have 2 chronic conditions or not. So there have been many different smaller pilots across the state and across the nation on trying to build these links across settings of care. This is an attempt to build to scale. We don't have time for pilots anymore. We know from many little pilots that much of this works. With Medicaid in New York State, we're looking to ultimately get tens of thousands and then hundreds of thousands of patients enrolled in health homes across all the large systems across the state, and then expand from there.
But John, how many health homes do we have right now? 34. There are 30. The health homes was a major recommendation of Phase 1 MRT. There are 34 already designated. Another, I'm sorry? More designated as we speak. What this waiver amendment asks for is additional funding to improve the operation of those health homes as well as to extend them statewide. So it's not really a pilot. We're fully committed to the health homes as a mainstay of our Medicaid redesign effort.
The federal savings you outlined is $17 billion. New York is applying for $10 billion of that revenue neutral. Wouldn't it be a savings to the feds of $7 billion, or if not, would you outline what makes it revenue neutral?
Right. Revenue neutrality is a technical term used by the, required by the federal government. Any demonstration under 1115 application to the feds it's incumbent upon the applicant to demonstrate revenue neutrality. That means as a result of the waiver, the federal government will not be spending more than it would otherwise have spent. In this case, we have a added inducement to the federal government. Not only are they not going to be spending more, they're actually going to be spending less than they would have otherwise. So we think that inducement is part of the reasons, is one of the reasons that we're optimistic that the federal government will approve our waiver application.
And this is a 5-year plan?
Yes, it's fine.
What happens after 5 years when that savings runs out and yet the programs are up and running? Who would then foot the cost?
That's a great question. So the question related to what happens after 5 years when these programs are up and running. Well, many of these programs we're trying to do structural changes so that once and for all they're in place. You know, rebuilding a system in certain ways is a one-time cost that we don't have the ability to invest in right now. When you transfer, when you want to build primary care, you have to really put dollars in at the front end. This is, many of the programs are like that. But the others that are being designed and will be detailed extensively in this 100-plus page document on the web as we speak, go into details of how do you make sustainable supportive housing, for example.
How much of the 10 billion how much of this have we gotten if we save that? Right? We're saving 34 billion on phase 1, so 17 and 17. We invested 10 billion, what are we going to save in phase 2? I don't think you said numbers.
Yeah, so we haven't given an estimate on how much more we'll be saving based on this waiver because it's hard to quantify. Many of these proposals, for example, if you build primary care, if you build supportive housing, many things will reduce unnecessary emergency room use. Now, how much can you attribute to one factor versus another? It's hard to say. On the other hand, what we will be doing is we will be following all the programs very carefully as we do it. So prospectively, we can make any mid-course corrections should any be needed, and we can quantify the big differences this makes. It's hard to project in advance. We will be able to give you numbers as we roll this out.
If you look at the waiver application itself, it has sections in it for each of the major investment categories that shows why we think those investments will produce savings. It references studies and pilots elsewhere. Part of the waiver is an evaluation, application is an evaluation component. So we're obligated to actually evaluate the initiatives that will be undertaken through the waiver.
And I know that part of this is to implement the Affordable Care Act. Obviously, we have set up an insurance exchange. Could you tell me how much of the 10 billion is going to that? How much is going to the insurance exchange? And what else we're doing besides the insurance exchange?
The healthcare exchange is separately funded under the provisions of ACA, that we don't need a waiver for that. And so we are proceeding. To date, we've received somewhere around $90 million to invest in putting up the exchange.
So then how much of this 10 billion would go to ACA? What will we do?
Really, this is not about the exchange part of healthcare reform. This is about the Medicaid part. As you know, under national healthcare reform, there's expanded eligibility for Medicaid. All the more reason that we have a very efficient delivery system in Medicaid, and that's what this waiver application is about.
Dr. Shah, do you anticipate that New York will ever, per capita spending on Medicaid, be closer to the national average? Right now, New York spends far, far more than other states.
So the question related to the per capita spending in the Medicaid program, you know, as New Yorkers, we've made specific choices about what Medicaid will provide our residents. And I think many of these choices have been very good ones. We've seen over the past year that there is significant capacity to lower the cost of the program while still improving access to the program and improving outcomes for patients. I can see us accelerating this trend over the next few years with the waiver, with the exchange, and continue to take out costs that everyone agrees don't need to be there while focusing on improving outcomes. My guess is that talking about the national average is hard. It's not really a valid basis for comparison. You have to see where we are and where we're going. We're going in the right direction, and we're going at a very accelerated pace toward the right direction relative to other states who may not be doing the same.
Just as a follow-up to my earlier question, after the American Reinvestment Act, a lot of states got into trouble because they got billions of dollars. New York, I think, got 11 billion over several years. And they used it to fund programs that were then still in place once the federal money went away. What assurances do New Yorkers have that this won't add billions of dollars in costs in 2017 when the waiver would run out?
Well, as you know, part of the MRT-1 recommendations, really perhaps the foremost feature of the MRT-1 recommendations was the enactment of a global budget cap, which tied Medicaid state share growth to a 10-year rolling average of the
CPI.
this medical care component of the CPI, from Mr. Raskin. So, I mean, we're committed to that. We've been working with the providers throughout the entire industry to manage our Medicaid program within the framework of that global cap.
What I'm asking is, would this blow a multi-billion-dollar hole in New York's budget in 5 years when this
No.
No, it's exactly the opposite. These are investment funds that are helping us to restructure the Medicaid program so that it can live within the lower cost structure that has been initiated by MRT. Yeah, so we'll give you some examples, okay? I mean, one of the things we're talking about with the waiver investment is expanded supportive housing. This is very innovative to tie housing to the Medicaid program. Yet we know that some of the highest cost users in Medicaid are people who don't have access to appropriate housing. It's their failure to have secure housing that helps drive up Medicaid costs. So one of the things we're looking for in this program is the opportunity to invest in expanded housing for high-cost Medicaid recipients, people with behavioral health needs, people with physical disabilities, chronic illness, and disabilities. So that kind of investment we think will produce long-term savings. Many of the healthcare providers have the wherewithal, another example, many healthcare providers have the wherewithal and the know-how to convert to lower cost structures featuring more ambulatory services, more outpatient services, more upfront preventative services, but they're being restricted to do so because of legacy costs that they have with the old institutional system, costs invested in old buildings and structures. We're looking for investment funds that are going to help us pay down that old debt at a faster rate than we would otherwise be able to do so these providers can move more quickly into the ambulatory services, which are the key part of the large key to lowering the cost profile in Medicaid. Exactly. We're talking about technical assistance, supportive housing, preserving safety net hospitals, retraining the workforce. These are investments that will lead to lower costs later on.
So the 13 areas that we've suggested that we're going to invest in with this waiver include primary care expansion, health home development, new care models, expanding the vital access providers and safety net providers program, public hospital innovation, Medicaid supportive housing expansion, long-term care transformation and integration to managed care, capital stabilization for safety net hospitals, hospital transition, ensuring the health workforce needs in the new era of healthcare reform, public health innovation, regional health planning, and an evaluation program. Full details are on the net.
Well, we submitted the application today. We've already been in discussions with CMS. As I've indicated, there are a lot of states looking for CMS approval on various types of waiver application. We are hopeful that they'll be able to work with us over the next several months. Ideally, we'd like to have this waiver in place as we begin our next fiscal year.
Shall we open it up to the support, the stakeholders? If any of the validators would like to come up and say a few words, please feel free.
Thank you, Commissioner. I'm Ken Rasky, President of the Greater New York Hospital Association. Today is a big deal. Make no mistake about it. I can't underscore that statement enough. There's a prepared statement I have over here, but forget about that. What's really important, as the Commissioner and Mr. Intron have said, is that we are putting in place structural reforms of the healthcare system. The foundation was laid with the global cap. Now these are the tools that are going to be necessary in order to make sure that we stay within that cap. And the savings to the federal government of the United States is enormous. And it will be, I guess there was a question over here, it will be a well that will keep on giving. It will be self-funding over the long haul because it will induce these structural reforms. So my compliments to the governor and to the executive branch for an outstanding job, and now we have to bring it home, as you said to me earlier.
Thank you, please.
Hello, I'm Ted Houghton. I'm the Executive Director of the Supportive Housing Network of New York. We represent 215 nonprofit providers of supportive housing, which is affordable housing with services on site for anybody who needs a little bit of help to stay housed. I want to say two things. One, this has been an extraordinary process. I think that the Medicaid Redesign Team, when I first heard about it, I wasn't really sure what it was going to be. I've never seen any kind of endeavor so comprehensive, so inclusive, and really ambitious. And I think the fact that housing is a part of this is representative of that. 20% of the people on Medicaid are costing 80% of our Medicaid spending. For this group of people, housing is health care. There's about 400,000 people with behavioral health problems that are causing them to use the system in such a way that they're using emergency rooms. They stay in inpatient hospitalizations much longer than they need to be. And by placing those people in supportive housing, you're able to reduce those inpatient hospitalizations at emergency department use by about 40 to 60%. And by giving them the services in the community, services that are already paid for by Medicaid in many cases, well, now we're going to be able to deliver them in the housing where they live, where they'll be even more effective. And we're going to be able to reduce this use, the expensive kinds of things that we spend money on. And not only will it create savings in Medicaid that will last far beyond what the waiver period is, it will also create savings in shelter and in various other kinds of high-cost psychiatric hospitalization that the state and localities spend money on. So it's really a great day. I think that it's a negotiation with the federal government, but I'm sure that the facts are on our side, and so I think it's going to have great success, and it's going to be a model for many other states. So thank you very much for all your work on that.
I'm Harvey Rosenthal. I'm with the New York Association of Psychiatric Rehabilitation Services. In doing so, I represent thousands, tens of thousands of Medicaid beneficiaries, many of them with psychiatric diagnoses and substance use problems. We're very grateful to the governor and the Department of Health staff for the process, which was so inclusionary. Webinars, forums, meetings, really countless hours where they really heard. We can see that our message was heard. And our message in many ways is simplified as recovery and wellness is much more than doctors and pills and hospitals. We have to look at the social determinants of health, and they've done that here in this document by funding housing, by funding peer support, outreach and engagement, and for all kinds of cultures, really recognizing our need to reach out to people of color, for example. So I think the proposal is really very strong, and we're very much in support of it.
Good afternoon. My name is Paloma Hernandez. I'm the President, Chief Executive Officer of Urban Health Plan. We're located in the South Bronx. We service both South Bronx and Corona, Queens, both very, very underserved communities. And I congratulate Commissioner Shaw. I congratulate the Governor, Mr. Introne, for this great movement towards transforming the healthcare system. As a person who's been out in that community for many years, I understand the needs. I have been part of the MRT process, which I first looked at a little bit in disbelief that it would really happen, that it would really capture the number of stakeholders that they were proposing to capture, and it really worked. I served on 2 of the work groups, and we came up with, it was a wonderful process. It came up with really good recommendations, and I'm really glad to see that they hopefully will move forward. As we transform the healthcare system, as you try to reach the triple aim of better health, better outcomes, and lower costs, it's really important that we put the patient at the center and that we put primary care at the center, because that's really where it all comes from. But when you look at our primary care infrastructure in the state, it needs a lot of development. I'm a federally qualified community health center. There are about 60 of us throughout the country, throughout the state. Many of our facilities need lots of improvements. We've been there a long time, need renovation, we need new space, we need just a lot more access to quality primary care. That, together with organizational infrastructure to support health homes, care coordination is great, it's very costly, and you need to build that infrastructure. And so I've done a lot of performance improvement work within our organization, and what I can say is when you try to improve a system, what you really have to do is take what you do and not add to it, but actually transform it. And I think that's what is being proposed, and I really congratulate New York State for the forward thinking. Thank you.
Good afternoon, I'm Debbie King. I'm Executive Director of the 1199 SEIU Training and Employment Funds, which is a joint labor management project that covers about 200,000 healthcare workers in New York State. I think that one of the things that we know is you can't transform the healthcare system without providing skills and a new way of working to the healthcare workforce. I know you were asking about outreach, people were asking about care coordination. These are skills that people need to learn, which they can learn, but we need to have resources to support the workforce. One thing that is really wonderful about the MRT process, and again, I would like to join in congratulating the Governor, Commissioner Shah, and Jim Introne for their leadership on this, is that it has brought all stakeholders together and has looked at all aspects. And many times the workforce is forgotten. And you cannot deliver quality care, you cannot deliver cost-effective care and increase access without a well-trained workforce. And this waiver will provide resources to allow that to happen. So we're really very, very much in support of this, and we hope all of you will join in that effort as well. Thank you.
So what I'll do is I'll ask all the validators to come up so that you know who they are. You've heard now from representatives of the patients, hospitals, primary care, and others, including the workforce, on how this waiver is going to transform New York State and how important it is that we all go to the federal government with one unified voice saying this is what New Yorkers deserve, this is what we can do to use to transform our health system. After this, perhaps a photo, and then we'll break up so that we can have individual consultations with anyone who has further questions. Everyone's on stage, if you can, Jim, get over here. And let's try to tighten it up.
Let me get behind you so we can. Let's get the tall people. Here,
I don't know, Debbie, you and I don't belong.
Jim, come on over here.
Jim.
Can you fit in? Dan, you want to get behind? We're in.
Thank you for having us. I think this is
Big deal.
yeah.
Wait till we get it, then you're getting put to work.
Yeah, I know that's the thing.
Thank you.
All right.
Thank you.
All right, nicely done.
Yes.
As always.
Very well said. I thought you did that, explained that very well.
Great explanation.
Congratulations.